we are very pleased to welcome the next group is going to be, we're very happy to, this is an exciting opportunity because in April, the international physicians and researchers came together in Dublin to have an international conference that hadn't been held since 2019. So I'm very pleased to welcome Dr. Anisha Dua, Dr. Elvis Berte, and Dr. Divi Kornick to the meeting. And Anisha, I believe you have slides. So Kaylin, can you let Anisha share her slides?
Yeah. Hi, everyone. It's really nice to talk with you today. I'm Anisha Dua. I run the director of the Vasculitis Center at Northwestern in Chicago. And Avisa, you want to go next?
Yep. I'm Avisa Berti. I'm actually a clinician in Trento, which is up north in Italy. And I work with vasculitis and I do research in vasculitis.
Divi?
Divi Kornick. I'm a professor of rheumatology at Brest University in France. And I also take care of patients with vasculitis and do some research in that field.
Great. So we're excited to be here to talk with you guys about some of the updates from that international conference that we attended. All of us are rheumatologists, but there was a lot of different subspecialties represented at the conference. And so we're going to try to do sort of a whirlwind through some of the different exciting research that's going on, so you guys can know what's new in vasculitis. I'll be starting off and I'll talk about large vessel vasculitis. And so GCA and Takayasu is what I'll be talking about. The first thing is about orbital vessel MRI and GCA. We know that we tend to rely pretty heavily on our imaging studies when we're evaluating large vessel vasculitis. And in cranial GCA, we tend to focus on the temporal artery. We know it was called temporal arteritis, but many other arteries can be affected. So this was a study that included patients with new or relapsing cranial GCA who underwent MRI of their brain in orbit. And so they looked at patients with ocular GCA, meaning the ophthalmologist looked and saw changes that had to do with their vision, versus non-ocular GCA, versus controls who didn't have GCA at all. And what they saw was that in GCA patients, there was enhancement or inflammation of the scalp, the maxillary, the facial, and the external carotid arteries. And most often affected was the temporal artery and the occipital artery. And this type of inflammation was not seen in the control, so not seen in patients who didn't have GCA. The MRI showed enhancement of structures that correspond with the posterior ciliary arteries. That's the main source of blood supply for the optic nerve, which of course is very important in vision. And this was seen in the patients who had ocular GCA, where the ophthalmologist said they had vision issues, but it was also seen in a subset of patients without visual symptoms. So this basically shows us that MRI may detect some subclinical ocular disease in GCA. So before people are already experiencing vision loss or vision findings on ophthalmologic exam, we may be able to detect some early signs of inflammation on MRI. And I'm going to shift here into some tools that we use in large vessel vasculitis. And we're always trying to add to our toolbox to see what we can use to treat these diseases. Of course, many of you have probably been on prednisone, and we know it works fast and it can be very effective, but it has a ton of side effects. So we've looked at many other medications to try to control this inflammation in the blood vessels. And some of the medicines that we use in large vessel vasculitis that many of you may have taken include medications like azathioprine, tocilizumab, mycophenolate mofetil, abatacept, different TNF inhibitors, methotrexate, leflunomide. And so we do have different things in our toolbox. But the hard part here is that we don't know specifically which medication is going to work for which patient. So what key fits specifically into the keyhole. And we don't have great head-to-head trials all the time. So it can be hard for us to decide what medication is the specific right one for each person. So we're always trying to discover more in terms of what we can add to our toolbox and how we can tailor the therapies. I think we're going to be hearing more about this pathway, the JAK-STAT pathway and large vessel vasculitis. As we learn more about what's going on in the disease, we can try to find these new targeted therapies. And we've found that vascular lesions, so the tissue in GCA and Takayasu's, have increased interferon gamma and IL-6. IL-6 is what is blocked by tocilizumab, which is a drug that many patients with GCA have been on or are on. And so these are all inflammatory proteins. And essentially, a lot of these proteins signal and create damage and inflammation using this pathway called the JAK-STAT pathway. And without going into much detail, basically, there are drugs that have been developed that stop this interaction and stop the JAK-STAT pathway. And they include baricitinib, tofacitinib, and upadacitinib. These have been in use in rheumatoid arthritis. And, we like to borrow whatever we can from some of our other diseases. And with this increased signature in GCA and Takayasu's, we're going to be talking more about these drugs in large vessel vasculitis. So baricitinib has been tried, and they presented this data at the conference in GCA. Why do we need new therapies? Again, I mentioned some of the reasons before. We know that steroid monotherapy, patients still suffer relapses 40 to 80% of the time, and it has awful side effects. Tocilizumab, which has really changed the game for GCA. We still know that up to a quarter of patients flare on therapy. And once that medication is stopped, about 50% will develop a flare. And as I mentioned, the JAK-STAT pathway targets these inflammatory proteins that are critical in driving inflammation in GCA. So baricitinib is one of those medications that blocks JAK1 and 2, and it was tested in relapsing patients with GCA. This was an open label study of baricitinib, so they all knew they were getting the medication 4 milligrams a day, and they were given a prednisone taper. The prednisone taper either started at 30 milligrams a day, 20 milligrams a day, or 10 milligrams a day. And the amount you were started on was just based on the clinical symptoms at the time of the relapse. And the prednisone was tapered down based on what they started on. So they were off prednisone by week 22 if they started on 30 milligrams. They were off by 19 weeks if they were on 20, and then they were off by 15 weeks if they were on 10. Who was in this study? About 15 patients, so it was a small study, 100% white, 73% female, and the mean age was 72 years. Most of these patients had had GCA for about 9 months, and most of them had already had one prior relapse. Now you can see some of the features of these relapses. Patients had headaches, polymyalgia rheumatica symptoms, constitutional symptoms like fevers, weight loss, malaise. And the first question we always ask when we're thinking about a new drug in vasculitis and in our patients is, was it safe? One patient in this study had a decline in their renal function. One patient developed herpes zoster, and 2 developed COVID-19 during this trial. One had a low platelet count. But importantly, there were no episodes of major cardiac events, blood clots, GI perforation, visual ischemia, or malignancy. And so did it work? That's the next question we like to ask, right? So there was a very significant reduction in the prednisone dose in our inflammatory markers like the SED rate and C-reactive protein, which we're often checking in our patients, and in patient global assessment, meaning you saying how you feel and how you're doing. One patient in the study had a relapse at week 24 and at 52, but the rest of them, 13 out of 14, were able to follow that accelerated glucocorticoid taper, and they were off steroids and in remission by the end of the year. So although the number of the patients was small in the study, the high remission induction and the steroid withdrawal rates suggest that this treatment is promising for GCA. And now moving on to Takayasu's, but the same pathway, tofacitinib is another JAK-STAT inhibitor, and it blocks JAK1 and 3. And it reduces interferon gamma, IL-17, and IL-21, again, all inflammatory proteins involved in the process of inflammation in GCA. So they compared tofacitinib to leflunomide. There were 67 patients from the East China Takayasu's arteritis cohort. 35 were treated with glucocorticoids and leflunomide, and 32 were treated with glucocorticoids and tofacitinib. And again, what we were trying to figure out here is, was this drug effective at 6 months? Were patients able to maintain remission? Did they have relapses? What were their labs doing, inflammatory markers, vascular imaging, and so on. So I'll tell you a little bit about the results. When they compared these two medications, there was no difference at 6 months in effectiveness. And the patients in complete remission at 12 months were also comparable, 80% with leflunomide and 75% with tofacitinib. When you look at the relapse rate, that was also comparable, 17% in leflunomide and 22% in tofacitinib. And importantly, in the patients who were started up with a glucocorticoid dose of more than 30 milligrams a day, the patients who were in the tofacitinib group were able to get a lower daily steroid dose than those in the leflunomide group, and that was seen at 9 months and also at 12 months. The frequency of side effects was also much higher in the leflunomide group, where 34% had side effects and only 9% in the tofacitinib group. So what does this all mean? Basically, leflunomide and tofacitinib have comparable treatment effects for patients with Takayasu's, but tofacitinib was superior to leflunomide in glucocorticoid tapering and safety profile. Again, smaller trials, but we need larger trials looking at these drugs. But there was a similar study that was done comparing methotrexate to tofacitinib. And again, the complete remission and steroid reduction rates were higher in the tofacitinib treated group. There are ongoing studies looking again at this pathway, looking at upadacitinib, another JAK-STAT inhibitor in GCA and in Takayasu's. And as we learn more about that pathophysiology, we know that there's other inflammatory proteins that can be targeted, including anti-GM-CSF and IL-17. And these other drugs I mentioned here, mavrilimab and secukinumab, are being tried in patients with GCA, targeting some of these other inflammatory pathways. So hopefully we'll get more to add to our toolbox with time. And then just to wrap this up, a lot of questions, a lot of patients ask me, who are doing well with GCA on tocilizumab, when can I get off this medication? We know that 73% of patients treated with weekly tocilizumab and then the 6-month glucocorticoid taper, which was really game-changing. Like I said, we used to just treat with steroids and more steroids. So these patients, a lot of them were in remission at 1 year. But after a year, when the drug was stopped, 42% maintained a tocilizumab and glucocorticoid-free remission, meaning they were still doing well up to 2 years after this therapy was stopped. And that's great for that 42%, but that means more than half of patients suffered from relapses after with drug withdrawal. And the patients who did experience relapse, luckily were able to regain remission quickly within 2 weeks after restarting the tocilizumab or tocilizumab and steroids. But again, they still did suffer that relapse. So it still can work when you add it back on, but we don't want all these patients having relapses. And there were no clear predictive factors for who will relapse or not off of tocilizumab, so which patients we can stop it in. So this trial was a prospective single center study in Italy. It was a small study again. Patients who were in remission after a year of tocilizumab weekly were switched to every other week dosing for the following year, and then the medication was stopped. So then they looked at them again after 6 more months, and they said, are you still in remission? And they found that 6 months after stopping therapy, 4 patients out of the 17 had a flare and were reinduced again with weekly tocilizumab and glucocorticoids. But this was looking at sort of, can we taper or pull back on the tocilizumab and still keep people in remission? So take-home points for large vessel vasculitis, some of the highlights from this conference were that MRI can detect subclinical ocular disease in giant cell arteritis. JAK inhibitors are being explored as a target for large vessel vasculitis, and early trials, even though they're small, have shown benefit with a good safety profile and the ability to reduce prednisone, which we know has all the awful side effects. It's still unclear how best to taper off or when to stop tocilizumab in GCA patients. I tend to start spacing after a year, but always you have to take into account prior relapses, damage, and patient-specific factors, and closely monitor how people are doing as we're trying to spread out and taper off this medication. And I will pass it on to Alvise to talk about EGPA.
Let me start by thanking the Vasculitis Foundation for the kind invitation. So for the next 10 minutes or so, we are going to focus on EGPA, but I'd like to start with this abstract that I find interesting. It's on ANCA-associated vasculitis, the whole group. And this is about a questionnaire, a specific questionnaire that had been administered in a rheumatology clinic in Sweden between 2008 and 2019 that was focused on patient information needs. And it turned out that besides other informations, that the patients really need information about the disease process and self-help measures and treatments, or particularly in these topics. And this is important to me because in my clinical activity, this actually really changed the information that I try to give to the patient. And to some extent, this highlights the importance of the patient-centered research that could also be impactful for the clinician. So the main abstract that I selected for the presentation of today, if Anisha could you please? Oh, thank you. I divided in 3 main topics. The first topic is those abstracts that try to better characterize the disease manifestation. Then there are some abstracts on the predictors and a better definition of the prognosis of the patient. And then there is a third topic, which is about treatments and new treatments. So about the first topic, I like to speak about, I made a couple of examples that I found particularly useful. One is about the better use of the tools that we have, the imaging. One of the main and most impactful manifestation of EGPA is the heart manifestations, since it could be really impactful on the prognosis of the patient. And this abstract is particularly important because it tried to better define how the manifestation actually are in the cardiac manifestation of the patients looks like at the beginning of the disease, and how the MRI imaging could be able to detect the response to treatment already at 3 months after therapy. So after 3 months of conventional therapy, as you can see here from the slide, there are an improvement in the myocarditis or in the pericardial effusion that are the most frequent manifestation that we could find in EGPA patients. And this tool, the MRI, is particularly sensitive and could register this changing already after 3 months of conventional therapy, which means glucocorticoids, cyclophosphamide, and azathioprine. So all the patients that underwent this imaging tool actually have an increased level of troponin, which is a cardiac biomarker, showing that there is probably cardiac involvement. So it doesn't mean that all the patients with EGPA have to do this imaging at baseline, but for sure, if there is the indication to do so, it's quite sensitive. It could allow us to understand if the treatment is working on the heart. And the next abstract, which is from another group from France, they try to make a better characterization of the pulmonary manifestation of the patients. This is a multicentric studies between of 3 main French center. It's a retrospective studies, but the important thing here is that they try to characterize all the pulmonary manifestation of EGPA. As you know, EGPA, pulmonary manifestation in EGPA are particularly frequent, and they were able to, based on this manifestation, to characterize 3 main patterns of disease, of pulmonary disease. One is bronchial pattern. The second one was ground glass pattern, and then there was a third group that didn't have pulmonary manifestations. So they were able to show that in the group 1, the one with the bronchial pattern, there was a better outcome, since the patients require less glucocorticoids and have a better rate of complete remission, while the ground glass pattern actually require more glucocorticoids and actually have a worse prognosis. These are just 2 examples. There were other studies that tried to characterize the disease, but these represent the effort of different clinicians and different clinical groups to better characterize this disease. And the next topic, I focus on the prognosis of the disease, and and one of the main studies presented was the definition of the predictors of EGPA. This was a very large retrospective studies on 8 or 9 patients that tried to define which were the main predictors of the disease course. Now, what we know so far about EGPA is that there are some patients that tends to have more vasculitis relapse, which means relapses that have clinical manifestations based on vascular inflammation, such as neuropathy, such as skin inflammation, purpura, such as glomerulonephritis, whereas other patients tend to have respiratory manifestation, which are asthma relapse or ENT relapse, like rhinosinusitis relapse. So these are considered to be a little bit different, especially because the treatment that we actually give to this type of relapses is a little bit different, with a higher and a different type of immune suppression for the vasculitis relapse, And while we usually treat with glucocorticoids only and or with mepolizumab, the asthma and ENT relapse. So this French group, in brief, they built two different models to try to understand which are the predictors of the vasculitis relapse and which are the predictors for the ENT asthma relapse. And indeed, there are different predictors for the different for the different models, for the different relapse. As you can see, for instance, in the left part of the slide, you can see that arthralgia, myocarditis, MPO-ANCA positivity, and higher levels of C-reactive protein are, among the others, predictors of vasculitis relapse during the follow-up. Whereas ENT manifestation and peripheral neuropathy, for instance, are, among the others, two risk factors of the ENT asthma relapse. So this, for sure, it's helpful and actually could help the clinicians to guide the treatment from baseline, maybe to intensify the treatment in the patient that tends to have a vasculitis relapse and so on. Of course, needs to be validated prospectively. And then in the last topic, I selected two main abstracts that have been presented. One is actually on the use of the anti-interleukin-5 treatment, the long-term use of anti-interleukin-5 treatment. As you know, since the MIRA study, the mepolizumab has been approved for the treatment of EGPA. And, but the problem from a clinical perspective is that we don't have a lot of data on long-term use of mepolizumab in patients with EGPA. So what the Cambridge group did is to observe 20 patients that were treated with mepolizumab 100 milligram every 4 weeks for at least 24 months, for at least 2 years. For the first 12 months, all the patients were treated with mepolizumab, then half of the patients switched to benralizumab or rislizumab. But in all the cases, there was a good complete or partial response with mepolizumab or benralizumab or rislizumab. More than 50% of the patient, more than 50% of the glucocorticoids were reduced in average, and actually after month 12, there was a lot of reduction also in other there was also further reduction of the glucocorticoids. And actually, there were also other benefits in using long-term anti-interleukin-5 treatments, such as the reduction of the immunosuppressive treatments, the reduction of the disease activity in general, and so on. So this abstract actually pointed out, even if it was a relatively small number, but this abstract pointed out that using the anti-interleukin-5 agents on the long run is actually safe and effective. And finally, I want to speak about the only phase 3 trial that has been discussed for EGPA, of course, that has been discussed in Dublin, which is the use of rituximab in EGPA. This is called REOVAS trial. So why rituximab for EGPA? As you know, rituximab could be used for EGPA, but actually there are no phase 3 trials showing the efficacy and safety of rituximab in this disease. In fact, is usually based because it has been shown that rituximab is non-inferior to cyclophosphamide in the other ANCA-associated vasculitis, namely granulomatosis with polyangiitis and microscopic polyangiitis. But there are no direct proof in EGPA patients. There are some retrospective studies in EGPA that you can see here in the slide that usually shown that it could work, and usually they actually show that there is usually a better efficacy of rituximab in ANCA-positive patients, but there is no prospective proof. And that's why REOVAS has been designed and conducted. So in the next slide, you can see that this is a double-blind superiority trial, which means that originally the physician wanted to show that rituximab was better as compared to the standard of care for induction of remission of the disease, which is usually cyclophosphamide. Patients were randomized 1-to-1, and the treatment, the standard of care, was based on the severity of the disease. So in the next slide, you can see the design of the trial. You can see here in the upper part of the slide that the patient that have a 5 FATO score higher than 1, which means a more severe disease, received glucocorticoid plus rituximab 1 gram 15 days apart in the experimental group. And while the conventional group received the cyclophosphamide followed by azathioprine with prednisone. The patient that have a milder disease, which you can see represented actually in the bottom of the slide, 5 FATO score equal to 0, but it's not important how the disease severity was measured. The patient with less disease severity actually received only glucocorticoids as a conventional standard of care group, while the experimental group received again rituximab plus glucocorticoid. And then the disease activity and the complete remission was assessed at 6 months. You can see that the patient actually enrolled in both arms. No, I was right, Anisha, thank you. You can see that the patients actually have the same features. The patient enrolled in both arms, rituximab and conventional therapy, have similar features. 70% of them approximately in each arm have newly diagnosed disease. About 60% of the patient have 5 FATO score of 0, which means a milder disease, and about 50 to 60% of the patient were ANCA negative. What about the results? So, as I mentioned before, the primary endpoint, so the main results of the trial was to understand if at 6 months rituximab was superior than cyclophosphamide, than standard of care. And as you can see here in the red square, the percentage of the patient that achieved complete remission was approximately the same, 60% in both arms, meaning that rituximab is not superior than conventional therapy, but is clearly good. It's clearly it has a similar effect to conventional therapy. So it could be used to induce induction of remission as cyclophosphamide. But then we also have other important information from the trial, is that actually rituximab didn't show any difference in cumulative prednisone exposure or adverse events, nor a higher efficacy in one of the subset. For instance, and in particular, we didn't see any specific effects of rituximab in the ANCA positive group as compared to the ANCA negative, or in the more severe disease as compared to the less severe disease. So what is the message here? Rituximab could be used for the disease, but of course the trials unfortunately didn't show a higher level of remission as compared to the conventional therapy.
Okay, and I take over the mic for the rest of the presentation. So we shared with Anisha and Alvise the highlights from the ANCA workshop in Dublin. So my part is about microscopic polyangiitis and granulomatosis with polyangiitis. So the conference in Dublin was really exciting. We had a lot of very interesting data on those diseases, but I decided to focus on only 2 points that have practical consequences. So first, new data on the use of rituximab for the prevention of relapses for GPA and MPA, and then new data on, about targeting the C5a receptor pathway. So first, what do we know about rituximab? When we get remission thanks to rituximab, patients do relapse after initial therapy. Around 25% of the patients at 1 year, and about 30 to 40% after 18 months. So we do need to use rituximab to prevent relapses, and that was also shown on the next slide during the main recent studies. So again, the next slide, please, Anisha. Thank you. And so the main recent studies was published already a few years ago and showed that rituximab is superior to azathioprine to prevent relapses. So I have a lot of animations, so you can click. Thank you. But this was the results of the initial study with a 2.5 years of follow-up. So what happens after we stop rituximab after 2 years of therapy? On the next slide, patients start to relapse again with almost the same numbers, around 20% of relapses at 1 year and 40% at 2 years. So there is really a strong debate about how long we should use rituximab infusions to maintain remission and avoid relapses. So on the next slide, please, Anisha. So this was also evaluated in a prospective clinical trial that was published 2 years ago, the MAINRITEN-3 study, in which we compared 2 years versus 4 years of treatments with rituximab to avoid relapses. And we showed in this study that if we extend the duration of rituximab treatment, we decrease the number of relapses. But if we look at the curve on the lower right part of my slide, we can see that almost 90% of the patients actually did not relapse after 4 years of therapy, whether they had 2 years of rituximab or 4 years. And so the new data that were presented in Dublin was those curves presented by Benjamin Terrier from Cochin in Paris. In this work, we reanalyzed all data from the MAINRITEN program. So the first MAINRITEN study that proved that rituximab was superior to azathioprine, and then the MAINRITEN 2 and 3. And the MAINRITEN-3 was to compare 2 years versus 4 years of treatment with rituximab. And the main information we got from this work was that it does not change much after almost 7 years of follow-up, so at month 84, after the beginning of treatment, if we gave 18 months versus 36 months of rituximab, if we use fixed intervals. But in the MAINRITEN-2 study, we try to decrease the number of rituximab infusions using NCAs and B cells as biomarkers. And so patients in this blue group, so the blue line, had less rituximab infusions over the first 2 years of treatments and actually did relapse more, even at the same rate as patients who received Imuran or Imuran. So the duration of therapy is still a matter of debate. On the next slide, and we do know that rituximab is effective to prevent relapses, and probably 2 years of treatment is enough for most patients if we use semestral infusions of rituximab, but longer periods of treatments can be discussed, of course, individually for each individual patient. So those were the data about rituximab, and the next slides are about targeting C5a receptor pathway. So we already have a drug approved on the market, Avacopan, and we have a new one that is getting evaluated. So I won't get into those complicated details, but we discovered only 15 years ago that the C5a, which is a soluble marker we can detect in the blood, is very at the center of the pathology. And that C5a itself is able to create the inflammation we see in patients with ANCA-associated vasculitis. And so the idea of targeting C5a with drugs was started around 10 years ago. And 2 years ago, Peter Merkel showed the results of the ADVOCATE clinical trials that compared Avacopan to prednisone to induce remission in patients with AAV, and then to maintain remission over 1 year. And so on the next slide, the main results of the ADVOCATE study is that Avacopan is as effective as steroids to induce remission 6 months after the beginning of therapy, and could even be superior compared to prednisone to maintain remission over 1 year. And so we have a few new data that were presented in Dublin about this study, and with a very important point about the quality of life, which is, of course, one of the main goals we have when we treat patients. And those kind of graphs are a bit complex, but we use a score which is called the short form 36. So it has 36 questions that interrogate the different facets of quality of life. And the bigger your circle is, the better your quality of life. And so in this study, we observed that the quality of life is better for patients who received avacopan compared to patients who received steroids. And the second abstract I chose to discuss today is about a new drug that is being developed to target C5a, which is called vilobelimab, which has a different mode of action compared to avacopan, since it's a monoclonal antibody that targets C5a. And so this is a phase 2 study, so with a small number of patients, but with very interesting results that show that this new drug could also have the potential to replace steroids in the treatment of AAV. So of course, this is a phase 2 trial, so we will need to wait for a phase 3 trial with larger number of patients to conclude that we have a new drug, a new candidate drug targeting the same pathway. And so my last conclusions slide. Avacopan is available, so we are using it to treat patients currently, but its indications still have to be discussed in terms of duration of therapy, for example. And we have a real hope to get new drugs targeting the same pathway quite soon. So thank you very much, and I think we'll be able to take a few questions. Oh, we can't hear you, Joyce.
Thank you. How about now? Can you hear me? Oh, great.
Yeah.
Yeah, so we're a little over time, but I'd love to ask you a few questions that came in through the chat window. And if one of you can decide which one you want to answer. I think the last question was about, Divi, your question about your slide for eGPA that talked about prognosis. Was that saying that relapse is generally at 2 years for the ENT asthma group?
I think that was
That's a question for Alvise.
Yeah. Okay, sorry.
Okay, yeah. So regarding that slide, I just wanted to clarify that, first of all, a hazard ratio, there was also a question, hazard ratio, I guess, it's just a way to measure the risk. Somebody was asking about the hazard ratio, what does it mean, how a patient could read that slide. So I maybe didn't realize that it could have been a little bit messy for a patient. I just wanted to clarify that is a way to measure the risk. So the higher this number, the higher the risk of having the outcome with that specific variable. For instance, arthralgia has a ratio of 1.32. It means that if you have arthralgia, you have a risk of 32% more of having that manifest or having a relapse as compared about not having arthralgia. And the second question that was about the prediction at 2 years is just how the model is built. It means that the authors looks during the first 2 years after the diagnosis if there are asthma or ENT relapses. So it's just the time frame in which the authors are looking for the outcome. That's the explanation of the model.
Okay, great. So can someone talk about the common side effects of avacopan compared to prednisone, and not a deep dive?
Yeah, so in a few words, the side effects of the tolerance profile was evaluated in Advocate, and especially using a score called the GTI, the glucocorticoid toxicity index, that proved that avacopan has less side effects for what is usually attributed to steroids, and it has a few specific side effects, especially about liver abnormalities. So it requires a regular biological workup, but overall, I think we can definitely say that it has less side effects compared to steroids.
Okay, great. Thank you. And we're a little over time, but at the conference, one of the biggest issues our patients talk about is fatigue. Did any of you see anything really, really exciting about exploring fatigue? You know, what causes it, how we can address it? And I'll throw that open to anybody who wants to answer.
Yeah, this is a tough question, which is transversal to all of our inflammatory diseases and not specific to vasculitis. And so probably part of the fatigue is directly linked to the disease itself and its inflammatory activity, but some of it can also be attributed to the drugs and the consequences of the drugs. For example, quality of sleep when we take prednisone is not always perfect, so this leads to fatigue. And fatigue has many different dimensions, including psychological dimensions. And getting diagnosed with this type of disease can be hard, and this also can be linked to fatigue, I think.
Yeah.
Any final comments? Anisha, do you want to
add? No, I
anything?
agree. I think they commented on a lot of it. It is really multifactorial, which is why it's very hard to study, and everyone experiences that in a very different way. You know, there's concomitant fibromyalgia along with vasculitis. People can have sleep apnea, all the medications. So I think it is a very difficult thing to study. I know people have tried different nutritional stuff, exercise. We know that all these different sort of lifestyle things do play a role in fatigue, but it can be hard to tell someone to exercise if you have ability and you're unable to do so. So I think, you know, it becomes a very individualized process. So it's definitely a good question that we don't have great answers to. Hopefully we'll be able to offer more in the future, but because it's so multifactorial, I think it's very difficult to get a really good answer on how to treat fatigue.
Great. Okay, I'd like to thank all three of you for joining us today. Divi and Alvisa from France and Italy, thank you so much for, it's probably evening there, so I hope you can go out for a late dinner or something.
That's the plan.
Thank
Thank you very much.
Thank you all. Have a good day.
Bye.